Man, unlike most animals, is born with his nervous system immature. During ontogenesis, posture develops first. It's characteristic only for humans and comprises extension, i.e., straightening of the spine, trunk rotation, and the ability to abduct and externally rotate the extremities. Morphological maturation of the skeleton goes hand in hand with the development of these functions. Postural ontogenesis is automatic, triggered by optical orientation and the emotional needs of the child. It is genetically determined and it consists of motor patterns which are the basis of automatic involuntary motor behavior. The following two motor functions play a key role. Stabilization of the spine in the sagittal plane takes place first. It is linked to optical orientation and is accomplished by the end of the 4th month. It is the result of the muscular coactivation required for erect posture. The postural prone pattern and the supine are identical in principle, differing by the points of support. Phasic movement develops only after stabilization in the sagittal plane has been achieved, by which we mean primarily stepping forward or grasping and the support function. All are related to trunk rotation. The stepping forward and support functions develop according to two distinct patterns. 1. Stepping forward or grasping and support take place on the same side at arms and legs. 2. Stepping forward and support function are on opposite sides. At first, homolateral pattern develops, i.e., stepping forward and support take place on the same side at arms and legs. At first, grasping takes place from the side. After 4.5 months, in the central plane, and in the 6th month, grasping induces the pattern of trunk rotation. In this case, the lower leg and arm serve the support function, and the upper arm and leg that of stepping forward. 2. Stepping forward and support function are on opposite sides. This pattern can be seen as grasping develops in the prone infant at the age of 4.5 months, in a prone position at 6.5 months, and later when the pattern of crawling on all fours and straightening up develops. Motor patterns which mature in the course of postural development can be evoked by reflex methods. These patterns are centrally controlled and explain the functional pathology of the motor system. By a degree of pressure which must not be nociceptive, it is possible to evoke a motor response which corresponds to spinal stabilization in the sagittal plane, achieved at the end of the 4th month of postural development. This is followed by the stepping forward and support reactions of the extremities. Pressure for stimulation must have the right direction and should vary. The main patterns resulting from stimulation are rotation and creeping, depending on the position of the stepping forward and support extremities. These are the two basic genetically determined motor stereotypes which cover partial motor patterns of postural ontogenesis. They are overall patterns by which the entire striped musculature is activated. Reflex turning is the result of coordinated muscular stabilization which can be followed up by succession when the child flexes the legs supine at the age of 4 months, when grasping beyond midline at 4.5 months, when turning to lie on the side at 5 months, when turning over at 6 months, when supporting itself on the elbow lying on his side at 7 months, when sitting up in an oblique position at 8 months, and walking sideways at 12 months. This development is under the constant control of the CNS. These patterns of muscular activity can be evoked in man at any age by reflex stimulation. The pattern of stabilization in the sagittal plane is the first to be evoked by reflex stimulation, followed by stepping forward by the homolateral extremities. The function of the contralateral extremities is to support and to take off. This is a reciprocal pattern. The articular head moves against the joint cavity in the stepping forward extremity. The joint cavity moves against the articular head in the supporting extremity. The two functions differ in the direction of muscular pull. The stepping forward function is linked to head rotation in the direction of forward stepping and to rotation of the spine. Movement and its development occur under the most favorable biomechanical conditions if the CNS is normal. The principles of neurophysiology and biomechanics work in harmony. Any purposeful movement is closely related to the spinal stabilization based on the programs which come into play during early development. Muscular coordination between the spinal extensors, the deep neck flexors, the abdominal muscles, the diaphragm, and the muscles of the pelvic floor ensures appropriate intra-abdominal pressure. Activation of these muscles during any movement is automatic. Impairment of this function, important for all our movements, limits compensatory capacity of our locomotor system. Insufficient deep stabilization of the spine is a key factor in etiology of many motor lesions. We will now demonstrate a few tests which can be used for evaluation of the deep stabilizing system of the spine. Palpation of the lateral group of the deep abdominal muscles is performed thus. We ask the patient to exert counterpressure against our palpating hands with the thorax in an expiratory position. No flexion of the spine should occur. Coordination of the diaphragm and eccentric contraction of the lateral part of the deep abdominal muscles is tested in this way. Signs of insufficiency are the inability of the patient to press with the dorsolateral part of his abdominal wall against our fingers, and a cranial movement of his ribs during the activation. The patient cannot keep his chest in an expiratory position. Both signs result from insufficient activation of the diaphragm and the pelvic floor, which therefore cannot ensure appropriate intra-abdominal pressure. Stabilization of the spine from front is disturbed. This examination can also be carried out with the patient supine. Signs of insufficient stabilization is the prevalence of activity in the upper part of the rectus abdominis. Cranial movement of the umbilicus can be observed when the patient tries to activate the lateral parts of his abdominal wall. The sternum and the ribs also move in a cranial direction. This again is a sign of insufficient activation of the diaphragm, which should move in a caudal direction during the activation and the weakening of the lower part of the transversus and the rectus abdominis. Respiration always goes hand in hand with postural stabilization of the spine. We observe movements of the chest during respiration. We assess ventrolateral or cranial movement of the sternum and the ribs. If there is good stabilization, the patient can breathe with his chest in an expiratory, i.e. caudal, position without the breastbone moving up. During examination, we passively bring the patient's chest to the caudal position and ask the patient to breathe while maintaining this expiratory position. The sternum moves only in the ventrodorsal direction. The axis between the ventral and dorsal parts of the diaphragm reaches horizontal position and does not change in the course of physiological respiration. This is a crucial position. The area of the lower ribs and the lower part of the sternum is where attachments of the abdominal muscles and the serratus anterior communicate. The chest is kept in an inspiratory position if the deep stabilizing system is insufficient, and the sternum and the ribs move in a cranial direction during respiration. The intercostal spaces do not widen. This pathological cranial movement can also be observed in the jugular area. The fulcrum, axis of rotation, is not at the sternoclavicular but at the acromioclavicular joint. Under physiological conditions, the sternoclavicular joint does not move in a cranial direction. If there is a pathological stereotype of respiration, there is increased concavity of the diaphragm, and the axis connecting ventral and dorsal parts of the diaphragm is oblique. Its direction changes during respiration. The axis between the ventral and dorsal parts of the diaphragm reaches horizontal position and does not change in the course of physiological respiration. The pathological stereotype of breathing results in a poor stabilization of the spine from front and in overloading. The stereotype of breathing can also be examined with the patient sitting. We palpate the angles of the lower ribs following the movements in the course of inspiration and expiration. Under physiological conditions, they move in a lateral, not cranial, direction. During inspiration, the lateral parts of the abdominal wall below the lower ribs bulge. The stabilizing function can also be examined during the movements of both the arms and the legs. For example, the sitting patient slightly flexes his leg at the hip joint. If the deep stabilizing system of the spine is insufficient, there is hyperactivity in the paravertebral muscles and in the upper part of the rectus abdominis. Only minimum or no activity can be palpated in the lateral parts of the abdominal muscles during hip joint flexion. Every movement of the leg is made with poor ventral stabilization of the spine, resulting in repeated overloading. In some pathological cases, we observe not only hyperactivity and overloading of the paravertebral muscles during hip flexion, but also slight lateral movement of the TL junction. Under normal conditions, stability of the TL junction is ensured by the activity of the diaphragm and the posterolateral group of abdominal muscles. Movement of the ribs is examined while the patient bends forward. If the deep stabilizing system is weak, the ribs move to the side and the lateral part of the deep abdominal muscles bulges. With treatment, we try to influence postural stabilization, which is a prerequisite of all our purposeful motor functions. We make use of the principles of reflex locomotion or positioning with manual contact to exercise functions of postural stabilization. As an example, we will show you how to exercise spinal stabilization from the front with the patient supine. First, we bring the sternum and the thorax into a caudal position during exhalation using our hands. With this maneuver, the caudal part of the thorax is widened. Concavity of the diaphragm decreases. In this position, the patient should support himself on the TL junction, which becomes the punctum fixum. At the same time, the patient tries slightly to lift his buttocks using his abdominal muscles. He should not, however, draw in the pelvis. The therapist's hand fixes the lower ribs at the level of the attachment points of the lateral part of the abdominal muscles so as to maintain their caudal position. The patient must learn how to control this function by himself. When we examine and treat disturbed function of the locomotor system, we make use of the basic functions of the muscles and joints which are determined by a program under the control of the CNS. Our goal is to make the joint function according to this program. To do this, we have to know the movement which corresponds to the locomotor pattern. Under physiological conditions, we do not meet any resistance during movement as long as it takes place in the neutral or mid position. Under pathological conditions, this pattern is changed. We meet resistance during movement. The pattern is changed in a characteristic way, in our case by a lateral shift of the pelvis. Mobilization takes place in the position in which substitution occurs. By manual fixation, we resist the substitution and continue with the movement of stepping forward. Muscular facilitation is used to improve the articular pattern. The patient makes the stepping forward movement against resistance from the position where the slack has been taken up. By this, the stabilizing function of the muscles is activated and transmitted to the segment to be mobilized. We may thus change the tension of the muscles at the mobilized segment, including the deep muscles which escape voluntary control, using isometric muscular activity by resisting the function of stepping forward. Mobilization and a change in muscular tension can also be achieved by stimulating special trigger zones by placing the joint into the position in which the slack is best taken up. In this way, automatic involuntary muscular activation is achieved, obtaining normal muscular tension.